Hello, and welcome to another edition of Airway on Demand podcast interviews. I am your host, Dr. William Rosenblatt, professor of anesthesiology and surgery at Yale University School of Medicine. Today, we are recording from the Yale New Haven Hospital Smilow Cancer Center. We have on the phone today Felipe Urdaneta, who is associate professor of anesthesiology at University of Florida. And Felipe, I'd like you to also tell us something about your association with Society for Airway Management.
Well, I'm currently a co-chair of this year's SAMS meeting that is going to be taking place in Seattle. And I'm also SAM's webmaster, and I'm an active member of SAM. I'm proud and very happy to be part of SAM.
Is there anything you want to say about the meeting that's coming up in Seattle?
Yes, and the meeting I recommended to everyone that basically thinks that they need to know a little bit more airway, or actually are airway enthusiasts, and also those that actually want to polish their skills and knowledge with regards to airway management. We have a pretty balanced and well-designed conference that's going to be exciting, and nobody that goes there will be actually sorry that they did, because it's going to be a pretty good meeting. Any
sessions in particular that you're excited about?
She actually named the conference Back to the Future, so we're going to be looking past and also looking forward at what has happened. And I'm pretty excited about a couple specifically. I want to talk more about how robotics might be the future and how telemedicine is also going to be part of it. I'm also very interested in knowing what the current status is of the closed games projects, and also we'll be looking at that. Also very interesting, and which relates to this particular article, kind of, that we're speaking today. There's going to be an international speaker talking about what the status is of ultrasound. We've been hearing about ultrasound for quite a while, but I don't think it has gotten the attention and the penetrance that it needs. And I think hopefully by bringing this speaker, we can give it a little bit better, higher profile. So I'm very excited about that.
My interest is going to be, how does ultrasound lead us to make decisions in what we do with the airway?
I agree.
Michael Christensen, as you know, in Denmark, has done, I think, his best work regarding the confirmation of tracheal intubation and the confirmation of bilateral lung ventilation. He's shown ultrasound to be tremendous use there. And I'm still waiting for Michael to convince me about the evaluation part of ultrasound, but I think he's on the right track.
Yeah, I agree.
Okay. So you sent me this article, an editorial from Anesthesia by K.B. Greenland, and it was published this year in Anesthesia, a journal in the United Kingdom. And Dr. Greenland really discusses the issues regarding the multiple of devices that we have now been introduced into the airway market. But the question is, A, do they make a real difference? And B, how are we choosing how to manage airways with these devices? Is it haphazard? And is there really enough literature and careful investigation to justify both purchase of these devices and application of these devices and teaching? What did you take away from this editorial that you felt it was so important that we discuss it?
Well, I think what I like is the way he kind of put in context the status of where we are when we discuss airway management issues. And one thing that actually I took away from this article was that he was saying that it is 2014, so we're in the 21st century, and still our educational or our approach to actually teaching about airway management and airway products, as you mentioned, it's not very well structured. Yes, we have some certain ways that we do it, but still we're relying too much on apprenticeship model. And one of the things that also I agree with him is the fact that there's a lot of myths associated with airway management, something that gets passed from generation to generation without having the proper scrutiny, or basically without even us questioning whether those things weren't further research and structural research, so we can actually answer the questions that we actually have been asking ourselves for for many years, perhaps from the moments that we started actually instrumenting the airway. So that's what I really took from this article, kind of in a broad sense of the article.
Talking about the dogmas that he speaks about, they're pretty significant, and I think anyone who listens to this podcast, or for that matter manages airways, will be familiar with these dogmas. For example, the use of cricoid pressure, the three-axis alignment, the fact that many still consider the fiber optic intubation scope the gold standard for any difficult airway. These are not small things. These are things that really do affect everyday care and should be examined. I think him coming out of the United Kingdom, he also has probably more experience with non-traditional use of supraglottic airways, and is trying to discuss in his editorial that we probably can broaden the use of supraglottic airways in patients who are, let's say, in not the standard supine position, or patients who are having intra-abdominal surgery. So he really brings up these issues which many of us, especially those of us who've trained more than a decade ago, cringe at the idea of abandoning. But he does bring up the issue that they're not well researched, and we do need more data.
That's correct. And then the problem is that they get passed along from generation to generation, and they don't. I mean, people don't think they actually cannot act automatically without looking into seeing the logic behind it. And the other thing that has happened is that most of these dogmas, in my opinion, came out with the proper context of time. But since then, new devices or new technology, maybe even new pharmacology has surfaced. And it's time for us to question the wisdom of actually continuing with old dogmas when actually the playing field perhaps is changing. But it will not change until we actually have a little bit more data, because one of the things that also I think was very interesting from this article, which is something that we know, and that's something that I'm always kind of amazed by it, is that most of actually what we actually know about the airway is because of expert opinion. In other words, you give your opinion, and for example, when you that are well researched and you have a tremendous amount of experience and all that, when you say something that people believe you, but what if you actually have not done your proper scientific method to actually come up with your conclusion? Then I think that's a problem. So let's just say that 10 years from now, you and I sit down and say, well, ultrasound was not what we actually thought it was, and that will be okay, but at least ultrasound may afford us a window or opportunity to actually evaluate the way we actually are approaching our airway. And one of the things that to me is the biggest myth in airway management happens to be the preoperative evaluation. So in my opinion, any time that we actually can have kind of an opportunity to know something more objective rather than the subjective things that we've been actually discussing since the 50 years or 30 years or so, then I think it's an opportunity for us to review our methods, and also hopefully we can have a better assessment of patients, because we definitely need to. We take too many risks. We are oftentimes wrong, many times wrong, and the problem is, yes, most of the time, especially if you're an expert, you can get away with actually not assessing the patient adequately. But if you are not in inadequate circumstances, or you're not basically an expert, then inadequate evaluation can lead to disastrous consequences. So anything that we can have to evaluate the patients better, in my opinion, will be very beneficial.
I feel that some of the newer devices, when I say newer, I'm probably talking about the last 25 years, that is video laryngoscopy and supraglottic ventilation, have been great equalizers. So that if you have someone working in an ICU or remote environment who doesn't have access to, let's say, expertise or someone with a lot of experience, the fact they might have a supraglottic airway and may have a video laryngoscope kind of levels the field and gives them a higher rate of success. Absolutely, evaluation is going to be important. And in fact, in that scenario, it may be that evaluation leads one to say, I'm out of my league, and I should be seeking expert advice, and I should be seeking the technology, and along with that expert device, bringing that patient to the operating room instead of managing that patient in a remote location.
Yep. There's another thing of this editorial that I like, and I really recommend people from reading it, that I also found interesting besides of what we've discussed so far. And it happens actually to be something that the author said regarding the degree of evidence of how we should actually be progressing when we actually discuss airways and devices and all that. One of the things is that we I think obviously you know about this. Most of our references now deal with evaluation of devices in the simulator setting. And I think that's only one step. I think it's obviously this is a big stepping stone, but it should be a stepping stone to actually progress in terms of the level of evidence that we need to have for certain devices or techniques or something like that. Because if we just stay with simulation, well, we know that there's a lot of limitations with simulation, but it's an important step that we need to consider.
I consider the simulation, the mannequins, to be good for teaching process, but not the actual procedure itself.
I agree.
Alan Klock did an editorial a while back where he showed that the mannequins, if you look at the CT data on mannequin heads, they don't resemble human anatomy. What they are built to do is to work with the devices. And so I agree with you 100%. We can't rely on simulator or simple task trainer mannequin data to evaluate these devices. For better or for worse, it's really going to come down to the human model. Now, maybe someone like Richard Levitan in Baltimore at Shock Trauma has a wonderful model using a cadaver model, which he evaluates people's ability to do direct laryngoscopy. That might be an interesting model for looking at some of the video laryngoscopes or other devices.
Agreed.
Greenland, in this editorial, also hints at the idea that maybe the various new technologies will eventually be applied to particular sets of anatomy. For example, he makes the comment that though the channel video laryngoscopes do a very good job of avoiding and looking around the hypopharyngeal tongue, if a patient has a long neck, the channel video laryngoscope blade may not reach all the way to the epiglottis or larynx. So he's implying in a way that we may get to a point where particular technology is applied to particular anatomy.
One size doesn't fit all. I think that's a very important thing.
But do you think we'll get to a point where we'll be able to pick and choose the type of device that we can use?
No, I don't think so. I think what you are referring to, what he actually is talking in this editorial, if I recall, I will have to go back and read it again right now. But I think he was talking about a particular device, which is the Pentax, and not certain how much you used it. I'm pretty sure you have. And one of the problems that I used when I used the Pentax is that if the person is an indeed tall person, then the Pentax blade is not long enough to reach where you need to reach. And I think that's what he was referring to. And unfortunately, not much has changed from that particular device in terms of the blade development, as far as I know, because we have not received a new model that is particularly geared towards taller populations.
So does that mean that we should be putting our engineers towards developing universal devices, or should we be picking and choosing our device based upon our physical exam?
Well, I think that actually underneath that statement that I just said, it brings up a point that it's more important to have experience with the device you're using, and only experience allows you to actually come up with the observation. And I know I haven't done a randomized control study. It's just basically my observation. Every time I've had a tall patient, it has failed. So that's a valid observation that somebody with experience can tell you. And I think that when I've gone back, for example, to the company and I've said, can you please make a longer blade? They say, yes, we're in the process of developing a new blade, and which I think it's important, because I think one of the things is, despite the fact that there were several modifications of the curved and the straight blade since the 1940s, in reality, the technology was stagnant for 50 years until actually we started looking and saying, hey, you know what, we need to redesign and think what we have been doing.
Do you know the story about the LMA Fast Track 5X?
No.
It's not a well-known story, but when Dr. Archie Brain first introduced the LMA Fast Track, of course we had the sizes 3, 4, and 5. And soon after it was introduced in the United States, and one of the first users in the United States was Dr. Ovasapian in Chicago. Ovasapian went back to Archie Brain and said, you know, the 3, 4, and 5 are great devices, but in the United States, we've got these very tall people, and sometimes the 5 just doesn't work. As you know, the barrel of the 3, 4, and 5 are identical, and it's only the size of the mask and the position of the epiglottic lifting bar that vary. Well, Archie Brain came back and introduced something called the 5X, and the 5X had the cuff and the epiglottic lifting bar identical to the 5, but it had an extra long barrel, and this was specifically designed for the American population. I still have a 5X sitting in my locker here at Yale. I rarely use it, and I think there's probably just a handful of them sitting around, you know, in people's lockers all over the United States. But it just goes right along with the story you just told about the airway scope.
Gotcha. That's very interesting.
Yeah.
Never heard of it and never seen one. You have to send me a picture of that.
Or I'll bring it to the next SAM meeting in Seattle, which, of course, you are the co-chair of the meeting. And I look forward to seeing you there, and, of course, Dr. Armstead, who's the other co-chair of the meeting. And I can't speak for everyone else, but I'm looking forward to a really exciting meeting and to talking to you soon about other issues in airway management on this podcast.
One thing that I would like to add about the conference that I forgot to add is that for the first time we're going to be having a new pre-course, or actually a course that's satellite to it, by a guy named Will Rosenblatt. Oh, that's you. The AirwayOnDemand for the first time is going to be offered, which I think is going to be pretty good for people that actually can benefit from that pre-course, actually, so that they can understand things better if that airway is not something that they deal with on a regular basis. It's also great for people in training. So I'm really looking forward to that satellite course.
Thanks for the plug. I appreciate that very much. And this concludes our interview with Philippe Urdaneta, and I'm planning on having him on in future podcasts so we can discuss other issues in airway management. Thank you very much, Dr. Urdaneta.
Thank you very much, Will.
That concludes this episode of Airway On Demand podcast interviews. You can find out more information about this or previous episodes by going to www.airwayondemand.com and looking for the AOD PI button or tab. I also hope to see you at the upcoming Society for Airway Management meeting, which will be in Seattle, Washington, September 19th through the 21st. You can follow us on Twitter at AirwayOnDemand. And this is your host, Dr. William Rosenblatt, signing off and wishing you smooth airways.